This is the second presentation in the genitourinary tract imaging prepared by Prof. Sharaf. First, we'll deal with some congenital anomalies. As early as fourth week, we will find that there are some cells alongside the body of the embryo concerned with secretion and excreting the extra fluid, and these are called the pronephros. Then another one, longer, more differentiated, is called the mesonephros, and the mesonephros is formed of collections of cells with a duct system. The gonad is seen resting on this mesonephros, and then a ureteric bud comes down here, capped with this group of cells, renal cells, metanephros. Then all are going to open into the cloaca with the colon, with the rectum, and urogenital sinus, as well as the urachus. Here we have more differentiation of the metanephros into renal tissue, capping the ureteric bud, forming the collecting system, and this is the mesonephric duct capped with the gonad, and both are opening into the urogenital sinus, which is starting to differentiate into bladder, connected to the anterior abdominal wall through the urachus. Of course, this is the rectum. As early as 10th week, more differentiation will occur. Kidneys are well formed on either side, and ureteric bud is elongated and start to ascend up. The mesonephric cells with the gonads attached to them will be more differentiated into the genital tissue, and a new protrusion starts to bud out. It's called the Mullerian duct. So we have now three: Mullerian duct, original mesonephric duct and gonads, and the kidney. Of course, this is the urogenital sinus, where the Mullerian and the mesonephros and the ureteric bud all drain into, and the rectum is now separate. In the female, the gonads with the remains of the mesonephric ducts, mesonephric tissues, are now forming the ovary and the ovarian appendages, and the Mullerian is now differentiated into uterus, part of the vagina, uterus, and the fallopian tube. Still, the ureteric bud is elongated more to ascend and form the well-known kidney and collecting system. The urogenital sinus is now more differentiated to be capacious to form the bladder, with the urachus attached anteriorly. The Mullerian duct, original Mullerian duct, which forms the uterus and part of the vagina, is now opening separately, while the kidney is opening into the bladder. The kidney is drained into the urogenital sinus through the renal bladder. The rectum is separate. In the male, ureteric bud, metanephros, gonad, tes, appendicitis or ritis, going into the tests and forms the epididymis, originating from the mesonephric duct, appendicular testis, appendix of the testis. This is the vas deferens, which is formed by Mullerian duct, and a small bud is coming out here, will be the seminal vesicles, while another bud is formed here. Collection of tissues are formed here, and this will be the prostatic utricle. All of these are remains of Mullerian duct. Now, if we have two ureteric buds, this will be duplication with a supernumerary kidney. If you have only one metanephros, one ureteric bud, one mesonephric duct, this will be the normal. If you have two ureteric buds with one renal cap, this is called duplication or duplex with a single kidney. If we have two ureteric buds connected to each other, this is the bifid renal ducts. Failure to connect with the metanephros or premature branching and accessory bud. If there is failure to connect with the metanephros, this will be a blind ureter. And in the adult, there will be absent kidney. If you have one branch blind and one branch capped with kidney tissue, will have blind-ended ureter, and what we call ureteral diverticulum. And if you have premature branch without renal tissue, but separate, not like that one, separate branching. A separate branching is a blind-ended ureter like that one. So we might have blind-ended ureter without renal tissue, or blind-ended ureter with another new ureter and renal tissue, or a ureteral diverticulum. While the kidney is ascending, it is rotating, and if it rotates, what's draining the upper moiety is lower, and that's why we get this appearance. The upper moiety is drained down. We might get crossed ectopia, failure to rotate, failure to cross, to ascend, and then both renal tissues on both sides form one metanephric blastema, and this will form the crossed fused ectopia. So crossed fused ectopia is due to aggregation of the renal tissues on one side, and the upper moiety is draining downward because of the twist. As it ascends, it rotates, and usually if it is obstructed, it will appear as drooping flower, or the lower moiety is usually at a lower level than the expected. Horseshoe kidney is the commonest fusion anomaly. the partial inferior fusion of the metanephric blastomers across the midline could be formed of renal tissue and functioning, could be fibrous like here across the aorta and inferior vena cava, and usually are susceptible to stone formations, and usually there is hydronephrosis with multiple stones, and there is of course some degree of abnormal rotation or failure of normal rotation, with the ureter coming from the middle or ureter coming from the outer side, and the axes of the kidneys are reversed. Instead of being 30 to 45 on the vertical, they become 30 to 45 on the vertical in the reverse direction. So trauma, susceptible more to trauma, susceptible to form stones, form infection, are more liable to occur in such cases. Maybe fibrous, maybe functioning, maybe fibrotic. Of course, if you find renal anomaly, search for VATR. VATR means vertebral anomalies, tracheoesophageal anomalies, anorectal anomalies, and renal. Vertebral, anorectal, tracheoesophageal, and renal. VATR means you should search for other lesions like here, spina bifida. This is horseshoe kidney, and this is abnormality of the lower lumbar spine. Here the nephrographic phase of angiography showing the horseshoe kidney functioning across the vertebral column, and here is the medially directed calyces seen in such cases, and here is the renal blood supply from the lumbar vessels. Lumbar vessels share in such cases to give blood supply from the kidney. So anomalous arterial supply, abnormal axes, mal-directed kidney. Pelvic ectopic kidney is another anomaly. Ectopia means congenital abnormal location. Commonest is ipsilateral. Caudal ectopia, it may be cranial and intrathoracic, so maybe here or up there in the thorax. Associations, rotation anomaly, highly inserted or ectopic ureter, and extrarenal calyces. Extrarenal calyces means that the pelvis and major calyces are outside the confines of the kidney, and that's why they appear so full. This is ipsilateral on the same side, ectopic kidney ipsilateral, caudal, ipsilateral caudal on the same side, but sometimes you might find it intrathoracic. So pelvic ectopic kidney is the commonest, and the commonest is ipsilateral and not crossed. But crossed ectopia is usually partially or completely fused. Also, please search for VATR, vertebral anomaly, anorectal anomalies, tracheoesophageal anomalies, and renal anomalies. This is the crossed ectopia, and this is the crossed ectopia, one here and one there, and this is the MRI showing the crossed ectopia, and here is the axial showing the crossed ectopia, two kidneys. Unilateral renal agenesis. In unilateral renal agenesis, also think of Vater. So long you are dealing with congenital anomalies, always think with Vater. And in female duplications, you will find two ureters, two uterus separate. In the male, you might find the cryptorchidism, absent this, or cystic seminal vesicles or absent seminal vesicles. So in unilateral renal agenesis, you will not find the kidney, but think of other anomalies like here. As we can see, there are two uterus. And in males, you might find absent testes or absent or cystic seminal vesicles. Acute right renal obstruction due to right ureteric stone. Here it is. This is a stone. No excretion on the left side. No compensatory hypertrophy. Bowel loops at the left renal fossa. Then you consider the causes of unilateral absent function. Unilateral absent function could be due to absent kidney, could be due to absent kidney, or could be due to obstructed atrophic kidney, or could be due to removed kidney. Uretropelvic junction obstruction with multiple small stones seen inside. The main finding is sagging down of the lower margin, discrepancy between the size of the pelvis and the ureter draining, definite dilatation of the renal pelvis compared to the renal size, and dilatation of the major calyces as well as the minor calyces to a lesser extent. The main branch of dilatation is on the pelvis, denoting that the obstruction is high. This is a finding which usually seen. If the obstruction is lower down, the dilatation will be more proximal. If the obstruction is proximal, the dilatation is usually near to it. This is the normal, this is the abnormal. Uretropelvic junction obstruction, compared to the other side, there is definite dilatation. Compared to the calyces, there is definite dilatation. The main branch is pelvis, the sagging down of the lower margin, the convex bulge of the renal pelvis, and the discrepancy between the renal pelvis and the ureter. All such, and the presence of the stones, all denote that this is uretropelvic junction obstruction. A test can be done that you can do an erect film within the IVU series. The obstructed kidney will still hold, the normal kidney will be quickly drained. Left uretropelvic junction obstruction with massive left hydronephrosis, discovered in a patient with history of trauma and hematuria. Because it is very large like this, it is susceptible to trauma. Now we will talk about the degrees of hydronephrosis. This is the last degree in hydronephrosis. That is a degree where the renal parenchyma is converted into rims and decrescents. Rims and decrescents, rim like that, crescents like that, rims and crescents, and what appeal here is like just delineation of the cortex but no contrast within. This is a functioning renal parenchyma, only this thin rim. So this is, as we said, the last degree of hydronephrosis. If you remember the calyx is cupped. If you find the margins of the cups are rounded, this is first degree hydronephrosis. That means the fornices lost their sharp margins. Second is that the calyx is now not cupped, it is just flat or clubbed. So flat or clubbed calyx is number 2. Number 3 is that the calyx size, calyx diameter, the minor calyx diameter is dilated up to 1 centimeter. This is called 3, and 2 to 4 centimeter is number 4. And if you find calyces more than 2 centimeter like this with thin rims and crescents, this is last stage in hydronephrosis. The problem in hydronephrosis are many. One is the bad function. Number 2 is the susceptibility to trauma. Number 3 is the susceptibility for infection and converting hydronephrosis into pyelonephrosis or hemorrhage inside, and the of course stone formation. So here this is what we call nephrogram, showing nephrogram face on the right side normal, and here there is delay in the nephrographic density delayed function, and here there is excretion and filling of the calyces and pelvis and ureter. So it is 5 to 15 minutes, while here there is still no function, and only we can find the rims and the crescents. The CT solves the problem and showed that this is marked hydronephrosis with markedly thin parenchyma, last stage in hydronephrosis, stage of rims and crescents. There is a condition called congenital bilateral megacalyces or megacalycosis, where we find dilatation of the renal calyces without any evidence of obstruction, apparent obstruction, and this is called congenital megacalyces. This is very rare, but it happens that there is a condition like that. No apparent obstruction is seen. The main problem is marked dilatation and of course bilateral renal stones. So bilateral renal stones, bilateral marked dilatation, and the difficulty to find an obstruction are amongst the findings seen in congenital bilateral megacalycosis. Renal calculi in calyceal diverticulum. Sometimes in a plane you will find a collection of stones like here and there, which are not in line with the renal pelvis or known structure. That means that this might be either in a calyx or in a diverticulum of a calyx, and this is called the calyceal diverticulum, or what we call the calycine cyst. A calycine cyst is a cyst connected to one of the minor calyces. The rest of the minor calyces are normal, as we see here. So it is a cyst connected to a normal calyx. Here, a cyst connected to a normal calyx. This is called the calycine cyst or the calyceal diverticulum. You can find stones or milk of calcium. Milk of calcium means that there are some sediment of calcium. That's called milk of calcium, and it is in a large cyst in the region of the right kidney. Dromedary hump is a congenital anomaly that is typical at the mid portion. Here, if you follow the kidney, you find that there is a hump here. Same here, if you follow this kidney, you will find a hump. The main point to differentiate a mass from a hump is that you will find the interpapillary line, that is the line drawn connecting all these papillae. The interpapillary line is parallel to the renal cortical outline here, and the region of the hump is showing normal nephrographic phase and normal renal scan and normal CT renal tissue. This is a region in which we have a protrusion on the surface of the kidney, but no calyces are reaching here. That means that the interpapillary line is interrupted, so this is a mass. And here is the mass with no contrast injection, and here is the mass after contrast injection with peak sign at the margin, denoting that this is a hypernephroma. Pseudotumor or hypertrophied colon of Burton. Burton is a person, should be Burton, in which we can find calyces separated by renal tissue, and you will find some abnormal rotation, and on ultrasound you will find this area filled with the renal sinus tissue fat. So this is called the pseudotumor or the hypertrophy of the column of Burton. Sometimes prominent suprahilar lip can be seen indenting the right renal pelvis. So this is the right renal pelvis, and here we have a lip coming on top or projected like this one, without neck, just a pyramid opening without neck. This is called aberrant papilla, and these are called fetal lobulations. So we have fetal lobulations, and again the interpapillary line should be parallel to the cortex, and we have the aberrant papilla, and we have the suprahilar lip indenting the right renal pelvis here, suprahilar lip, usually vascular. All of these are congenital anomalies. You remember this image that ureteric buds are coming two instead of one, covered by renal metanephric elastima. If maybe one, maybe two. If two, these are supernumerary kidney. Then we have, if you are doing ultrasound and you have obliterated renal sinus, this is usually due to duplication like this, but sometimes it could be due to inflammatory changes, or it could be due to neoplasm. You should differentiate duplication from inflammatory changes from neoplasm if you find obliterated renal sinus. This is a urethroplasty in a duplex right kidney, avoiding this urethroplasty in a duplex right kidney, filling the two ureters on the right side. So it is associated with reflux. It's not only duplex, it's duplex with reflux. This is IVU, this is voiding ureterography, showing refluxing contrast into the duplex right kidney. Obstructed right moiety of duplex kidney, showing the drooping lily sign, as if there is something defective here, or something here pushing this down. This is due to obstruction of the upper moiety, which is pushing the lower moiety down. And here there is triplication. This is kidney with renal tissue, duplex 1, 2, and the third is a ureter here, extra ureter. This is called blind-ended ureter or ureteric diverticulum due to triplication of the ureteric bud. This is congenital blind-ended ureter, usually directed upward, but it may be directed downward. And amongst the complications, of course, is infection and stones. This is a kidney, this is ureter draining the kidney, but this one beside is a blind-ended ureter. It's another blind-ended ureter. So these are all examples of ureteric diverticle or blind-ended ureters, which could be site of infection or stone formation. This is an ectopic ureter, and usually ectopic ureter is accompanied by the appearance of a large filling defect due to the large urethrocoel accompanying such condition, as seen here. And the urethrocoel is the protrusion of the ureteric mucosa into the bladder, and here, because of the ectopic ureter, it appears as if there is a stone or filling defect inside. This is due to the inserted ectopic urethrocoel. Brown-Pelly syndrome or the Eagle-Barrett syndrome where we have gross ureteric dilatation, anterior abdominal wall underdevelopment, cryptorchidism, and this will be the appearance. Sagging bladder, sagging, capacious, markedly dilated urinary bladder, dilated both ureters, and no obstruction, no apparent obstruction, and the anterior abdominal wall is defective, underdeveloped musculature. Anterior urethral valves usually result in bilateral vesicular reflux and dilatation, hydrogen flows and hydrogen ureter with diverticuli in the bladder. And this is the appearance of an anterior urethral valve with a urethral diverticulum. Urethral diverticulum, this may be iatrogenic, but the valve is usually posterior. Here is the site of the anterior urethral valve. Anterior urethral valves are less common than posterior urethral valves. This is the filling of what we call the prostatic utricle. That part here, the prostatic utricle, sometimes is filled. And this is the site of the prostatic congenital urethral stenosis of the posterior urethral valve. Typical posterior urethral valve is at the verumontanum. Congenital massive hydrometrocolpus, secondary to Mullerian dysgenesis, and this is what we call imperforate hymen, imperforate membrane. And here we have the vagina and uterus filled with blood, altered blood, and this is urinary bladder. This is the typical appearance of the congenital massive hydrometrocolpus. This is due to Mullerian dysgenesis or imperfect membrane. Thank you.